Hi everyone, my name is Gabriela Galvis, and today I'll be discussing sexual and reproductive health service needs and the delivery of these services to refugees and displaced persons. Okay, so why does this matter to us? So, refugees and displaced persons are often stripped of stability, safety, and access to the most basic services. And among the urgent and very overlooked needs are those related to sexual and reproductive health, which are essential, as we know, to dignity and well being. The levels of displacement are staggering. Just in 2023, 67 million internally displaced persons were reported. So these are IDPs, and 6.87 million refugees were seeking asylum. And on top of that number, all on its own, there are 6 million Palestinian refugees recorded in 2023. So these numbers continue growing year after year. It only continues to get larger. So that means that the needs are also growing. So just to clarify a few things, um, refugees versus internally displaced persons. So a refugee is someone who seeks asylum outside of their own country, and IDPs or internally displaced persons are those people who are displaced from their home and they move to somewhere else in their country. So these IDPs could be moved multiple times before they actually leave the country as an official refugee. All right, SRH is sexual and reproductive health. So this could be anything from contraception to antenatal care or postnatal care, as well as STI prevention, HIV treatment. All of that is included in sexual reproductive health. And gender based violence, or GBV. So that is violence that is directly associated with a person's gender. Generally, it is from men to women. Displacement is devastating to a displaced person and community. It leads to the loss of community, any sense of stability, and the existing healthcare infrastructure that they may recognize could either be destroyed or unfamiliar now in a new country. SRH services are often the first to become inaccessible. So, this means that there will be increased risk of infection due to lack of STI care or any other sexual reproductive health care, and increasing risk of violence as well as maternal mortality. All right, and now we'd like to discuss the barriers to accessing sexual and reproductive health care. So these could range anywhere from structural to cultural, right? And a big part of it is stigma. So many women fear stigma or violence if they do end up seeking care, much less if they receive it. And these factors create a complicated, if not dangerous, environment for accessing these necessary services. So, for example, um, just based on geography, this could mean accessing, reaching out to a community that needs that care and hasn't been able to seek it, or even accessible equipment, something portable, something disposable. So, now we're going to discuss the relationship between gender based violence and sexual reproductive health care access. So, we know that sexual reproductive health care is essential, but how does it relate to gender based violence? So, existing gender based violence in a community already limits your access to sexual reproductive health care, right? But that lack of access then perpetuates further gender based violence. So you're caught in this loop where the violence deters your care, and that lack of care fuels the violence. So it's not optional, it's foundational. Sexual reproductive health care is an essential service. It should be reframed to be considered something so essential like food and shelter. Um, Ignoring this sexual reproductive health care needs, um, they lead to preventable deaths and poor health outcomes. So, multiple agencies do play a role in delivering sexual reproductive health care services through different programs, and they generally work together, but we'll discuss that later. So, we have governmental agencies, non governmental agencies, or NGOs. Then we have private foundations and UN agencies, and then community based organizations. All right, so now we have a couple of policies and programs. So, Title 42 in the US was a guide for the provision of health care to immigrants. So, this ensured that they were legally required a medical examination, and this meant for any migrant or displaced person within and without the US. And then we have the MISP. So, this is the Minimum Initial Service Package, and this is a program from the UNHCR that offers critical services to a country's people to be able to target the basic needs of the population, including SRH needs. So, some strategies that those programs did implement and that future programs will continue to implement um, are education, prenatal care, STI and HIV prevention, and family planning. So, these services do reduce mortality and support long term health for women. But the issue with these existing programs is that the aid packages are limited, right? So this is very limited for care and might not be all encompassing to what people need. So this definitely influences many conflict zones. All right, so I'd like to discuss the MISP implementation in Africa, okay? So it had some good points, some bad points, right? So first, Africa was had many different conflict zones, right? And they were seeking sexual reproductive health care for their internally displaced peoples. And what the UNHCR could offer was the MISP, right? So that program, since it was an initial service program, um, the sexual reproductive health services available were limited, right? But regardless, those services were necessary as well. So they get implemented to these different countries, and rather than everything going smoothly now that people are there, um, they encounter a new issue when they start to go out to the villages. So, um, male doctors generally populated these programs, and there weren't enough female doctors for the women there. And since that was such an important cultural need, um, it was critical because the program could not run efficiently. It could not run at all, regardless of if they were bilingual, if they understood the culture, everything. Well, if they understood the culture, they would recognize that the female doctors were absolutely needed for that community. Okay, so this brings me on to my next point. What is the most important thing for success? So, the most effective means to achieve this is through collaboration. So, programs work best when they partner with local efforts, right? So, community based organizations are this local effort. They bring cultural knowledge, they bring trust from the community members to our program, and it's essential for a success of a program so that you can understand all the context that you need in order to properly and respectfully implement uh, a healthcare need. All right, so as we mentioned before, there are many limitations to these programs, regardless of how good your intentions are, right? So these common barriers are language barriers, a male dominated service, right? So this gender access that might be a little difficult for women to feel comfortable in, and transport issues. So this is generally infrastructure difficulty, right? And these are issues where transport is too expensive or unattainable, maybe not frequent, or takes you much too far from where you need to go. So, regardless of your good intentions, those programs do fall short of meeting the needs of the people. So, these needs do extend to refugees and externally displaced persons. So, in lower middle income countries, the general issue is infrastructure, right? That's the main thing. So, overall access to the care is physical, and much of it is systemic. So, it makes it very difficult for people to even be able to find a good doctor or maybe um, timely care. And in high income country, we have enough doctors, right? So the US is a perfect example. And, but the main struggle is cost and insurance. As we all know here, cost to care is extremely high, and refugees and displaced persons in both high income and low middle income countries could struggle to achieve care only because of these barriers, right? These are going to be the main reasons, in addition to all the other problems that are bound to happen in the life of a displaced person. So, both these scenarios will delay care and worsen the outcomes. Okay, so finally, we'll discuss improvements, right, and innovations. So, some solutions could include bilingual staff or cultural coordinators, um, as well as mobile clinics. So, this could be for rural regions or places that seem inaccessible by any other means. And then cultural training for staff. This would be absolutely essential in areas that are rural and far uh, from any urbanized life. In conclusion, sexual reproductive health care must be central in any public health response to displacement. And addressing systemic, cultural, and logistical barriers ensures not only their survival, but their dignity and well being preserved. Beyond this, systemic change is needed in every country in order to adjust and be able to tend to the needs of any person, regardless of citizenship or status. Thank you all. These are my references, and thanks for listening.